Good evening, Dr. Saab. Kim Sho, how are you?
Delight to be part of this rather distinguished gathering, and thanks for making this happen.
No, sir, it is a privilege to have you. You're such a senior professional and a pioneer in this technology. So it's really a privilege that we have been able to get your time for this session.
Okay. Thanks. Shukriya. Abar.
I think, sir, generally we start off in by 5:35 or so, because people are tracking. I think we have already got 40 and more people joining. So just give us few more moments, and we'll start with a small presentation of our publishing partner, both stewardship, your introduction, everything. So maybe Ashish, you have given the word.
So I guess I will join again after 5 minutes. Well, I mean, I'll appear again after 5 minutes.
You can maybe stop your video and keep yourself on mute and stay with us that way, and we will call you out in another 4 to 5 minutes.
Okay, good idea.
Good evening, everybody. I hope I'm audible to all. You just do a show of hands. Thank you so much, Mr. Karni. So, very happy to have all of you here today for this very interesting and exciting session. We generally hold an Excellencia series every month to showcase the diverse topics and distinguished speakers who come to our forum to impart a lot of value adds to all our attendees. So, just before starting, small brief set of instructions to all. Kindly keep all your microphones on mute. So we have disabled from here also. Request you to ensure that there is no disturbance to the speakers. The chat box is on. Any questions you may have for the speakers, you can put in the chat box. And as and when the speaker would like to take the questions, we would be happy to roll it out to them. So at the end of the session, time permitting, if the speaker would like to, we can directly have people asking questions to them. Again, requesting everybody to continue till the end of the session to ensure that we get full benefit of the session. To start off, we will be displaying a short clip of our publishing partners, board stewardship, post which we will start with the session. Requesting to start the clip, please. So, to all the attendees, very warm welcome once again to the session. So, we have a great happiness and we feel great privilege in introducing our guest speaker for the Excellencia series today, Dr. Shrikant Parikh. Dr. Shrikant Parikh is the CEO and director at A3 Remote Monitoring Technologies. He is based in Mumbai and guides the business direction, product engineering, and technical initiatives of the company. Dr. Parikh is a very eminent personality and brings almost 3 decades of international experience as a technocrat from global corporate world, entrepreneur, strategist, and inventor. He has co-founded 2 other pioneering technology companies, InfoLife and Globe Ranger Corp USA. Before that, he has served as a business executive of IBM and a senior research and development member of IBM USA at their R&D lab. He has guided development of and shipped several successful products with involvement in all key aspects of production, product engineering, and launches. As an inventor, he holds 33 international patents and has published over 55 invention disclosures. He serves as a mentor for other high-tech entrepreneurial companies and a company director on many company boards. He has trained senior managers in technology management topics and serves as an adjunct international professor and a program architect for our top 10 business school of India. He holds PhD, MS, BE, and such degrees from various universities in India and the USA. He is listed in several editions of Who's Who. Dr. Parikh takes the deep activators in NGO activities focusing on rural India. His appreciation and concern for the rural world has often guided his products, entrepreneurial ventures, and inventions. He has organized multiple national, international conferences and job fairs for disadvantaged young professionals. With a person of such high distinguished career, I would not waste much more time and I would request Dr. Parikh to please take the stage. We'll just give a couple of more minutes since some people are joining in, and then probably we'll start with the main lecture session of Dr. Parikh. So, friends, uh, Dr. Parikh will be starting his presentation. I request all of you to please be alert to the presentation and I'll join as soon as possible. For those who are not joined as yet, thank you. Dr. Parikh, please.
Yes, it's gone. Hello, everybody, and it's an honor and delight to interact with such a distinguished audience of 123 people so far. So I really look forward to this interaction. Coming straight to the point, why we ended up at the spot we are at this particular station in life. Just to a brief history of time, three senior scientists, technocrats rather, came together, all associated with IIT Bombay. They came together. We want to make an impact. Where do we begin? Impact on society and our country. HDI, Human Development Index, depends upon number one on health. So we decided to focus on health. And we started peeling the layers. How do we as a scientist, technocrats, make an impact in the world of health? None of us are medical doctors. So let's start peeling the layers. So we began with kind of system engineering exercise, take a systemic view of the world of healthcare in India and even outside India. Whatever I'm saying is largely applicable even to Russia and USA of the world. So what is the number one problem in the world of healthcare? It's actually, number one problem is access. Here as well as USA. We need 10 times more cardiologists, 10 times more ICU bed, 10 times more nurses, more PSC, hospitals, primary, secondary, tertiary care hospital. That is not going to happen in near future, 10x. Currently, we are spending 2% on our health of GDP. It cannot be 20%. It's even in USA, it's not practical, which are distances are vast. We even have visited Russia, same problem, vast distances. Medical facilities are not there. Access is the problem. So how to take access of the existing infrastructure, access to existing infrastructure anywhere, anytime. And that actually explains the name of our company. A3 also mission, vision, plan of the company, anywhere, anytime access. I'm going to further expand on it. So what we exactly mean. So we as a technocrat, we took a system engineering view of how to crack this problem of access to healthcare, existing infrastructure. And that kind of was beginning of the journey. Even before that, what was the real concern? We began with the word HDI, Human Development Index, human. What is meant to be human and humanity? Concern for common man, saving 1 million lives unto the last. Unto the last, wherever the patient may be. It could be in Himalayas, it could be some Naxalite area, it could be downtown Bombay. And you get the picture, even somewhere in USA. The healthcare has to reach wireless to them. So these were our starting thoughts. And I will share a perfect roadmap, a proper roadmap of what all steps we went through to arrive at the station we are at. So before I will have to show inevitably certain slides in interest of time. So our plan, vision, mission is captured in the two words, two letters rather, A3, anywhere, anytime access. And this needed a lot of innovations, and we have won lots of number of innovations award. And our KPI is very simple: how many lives you are able to save, and another unofficial KPI is how many lives you are able to touch. So, and I will share all the statistics. Why is this important? This audience needs no, convincing. It is carrying coal to the Newcastle, as they say, a cliche. 2/3 rural population, timely attention intervention is key to saving lives. So even T2, T3, T4, T5, T7, they have the same problems. So there's a dearth of medical facility, even 60 kilometers from Bombay, where we have traveled all over. And all the ratios are bad: number of physicians and nurses and ICU beds and specialists. Like India has 2,000 cardiologists for a population of 1.4 billion. Okay, even in USA, if you want an appointment with a senior diabetologist, it can take 2 months. I mean, this is a yesterday story. And 2% of GDP, and that's where we are. It cannot be 20%. And some numbers, we have the worst pain to balloon times in the world, among the worst maternal mortality, worst infant mortality. Lot of that can be improved upon with the timely intervention and timely connection, access to healthcare. Okay, the easy fixes are not possible, even globally. And people say, okay, you are relevant to development countries, but some people say you're also relevant to developed countries because problems are very similar. Anyway, so now to make a grand statement, so what do we do in summary? Make healthcare accessible without restriction of space, time, and it could be any disease, any situation, any terrain, Himalayas or glaciers and deserts and so on. We are doing it all in a variety of manners. What I mean by that, I will show you pictorially and exactly show you what we mean by variety of manners. And all this has to run in hostile infrastructure of India. India, that is Bharat, this has to be India proof. So if you can do simple commonsensical multiplication, leads to combinatorial explosion of requirements. What all requirements have to be achieved. And in the end, the patient, doctor sitting, let's say in South Bombay, should be able to do remote patient management. It's not question of this doctor sitting here in Churchgate area, seeing somebody's temperature in Himalayas. That's frankly of not much use. Doctor should be able to do things with him. So we are talking about remote patient management. When we say healthcare, take it there to Himalayas, he should be able to manage a case. All these wirelessly, we are relevant to most of the world. So this sounds very pompous, but it's an audacious goal we began with. If you want to make an impact, you have to do all of this. This is not WhatsApp video call, as to put it humorously. Somebody says, I make a WhatsApp video call to my doctor. Now, where is your problem? Well, that is 1G or 0G technology. We are maybe at 6G and so on. Now, okay. Now, where is this needed? And there are 21 major segments where this kind of healthcare is needed. Anybody who is a consumer or a provider of healthcare needs to worry about how am I going to give access as a provider or as a beneficiary. A great example is defense. We've done a lot of work with Indian Army. I'll show you some pictures. Right at the border, if there is an injury and you have platinum 15 minutes to save a Jawan's life. And the situation is, not pretty. So that's one extreme example. Other extreme example is the street people. Now I'll show you those pictures also. It's somewhere in between is a hospital, hub and spoke, e-clinics, mobile medical unit. There's a world of NGO, CSR we are doing. phenomenal work. Home healthcare, assisted the elderly, the new rising trend of India, old age homes. So there are 21 major markets, and right now just Kumbh Mela ended today. We were the emergency service provider for Sabrimala some years ago, where crores of people came, not 50 crores, more like 5 crores. But as you can see, there are vast areas where healthcare is needed. And of course, how do you take it there? We submit one more time wirelessly. So we are going through system engineering type of thinking. We are peeling layer after layer. The moral of this story is you should be able to do it all. And we are doing it all. It could be eye, it could be pregnancy, it could be heart, it could be blood chemistry, it could be otoscope, dermoscope, dental, and on and on. We should be able to handle radiological images, pulmonary, and there is no limit. And you should be able to do it all. For example, in Mayavati, Himalaya, Chinese border, we have installation between Mayavati, which is actually a very well-known location, and Chinese border. There are few lakh tribals living, and there is no healthcare there. So something goes wrong, they go to this Mayavati center, which is a small community health center, 20-bed hospital. They don't bother to ask, do I have a myocardial infarction? Then only I can go. No, they will go with any medical problem. And therefore, when you take healthcare to remote areas, it better be a broad spectrum service. Basically, anything which is needed in a particular location. We were told in North India, pulmonary is a big issue. In South, in certain districts, dermatology is a big issue. So no two installations of India are same, no two organizations are same. Anyway, you have to do it all. In deep backwaters of India, often you don't get good pathological labs. So often people type random numbers, believe it or not. Okay, yes, this is your path lab report, and the numbers could be all wrong. And some people tell me, at least some, half the time those numbers we don't trust. So can we take portable blood chemistry analysis there? Yes, we can, and we are doing it already. So all I'm trying to tell you, when you say broad spectrum, it really means broad spectrum requirements. So now what do we do in a little bit more detail? We make healthcare accessible wirelessly for a variety of fundamental services. Now, what are those? I will, tell, remote patient management could be short term, long term, could be real time, live, ICU style. Okay, it could be expert consulting. It could be emergency response, 911 or military army application. It could be preventing, corporate wellness. The healthcare actually definition, it varies, from one end. At one end you have wellness service, and other end you have, of course, dying Jawan. All this has to work in a hostile atmosphere, rural area, or it could be corporate office or factories. OHS, occupational health services in factories, a really big thing. And we are active in that space also. E-clinics, where there is a hub and spoke model, hospital connected with 100 e-clinics, which is manned by, let's say, a nurse or a junior doctor. Home care. So that the context can vary dramatically. The healthcare requirement can vary dramatically. The disease area can vary dramatically. As you can see, it leads to a combinatorial explosion. All this has to be India proof. When I say India proof, again, through system engineering thinking, we realize there are 14 grant requirements. If you want to succeed in India, you have to satisfy 14 grant requirements. In a way, some people joke that, and it's not wrong, we are taking hospital outside hospital. So, actually we are relevant inside hospital too, but we'll go into it a little later. So what do? We to take this service in this variety of manners to variety of locations, variety of context. Applications, I shared some of them. Defense, my favorite, remote consulting, hub and spoke, corporate OSHA, occupational health services, long-term geriatric care. We have worked with geriatric institutions also, ambulatory cases, step-down ICU, and you can read them. And most importantly, T5, T6 locations, rural area, our favorite. It's one of the genesis of the whole journey. So example applications. So what is the roadmap we followed? Why we ended up at this station? So I will spend 30 seconds just taking through different steps of the roadmap we executed. As you can see, this is a a technocratic mind that when you are tackling a a humongous challenge, solving the healthcare problem of access, we have to go about it in a very systematic manner. So first of all, we decided that yes, health and education are two broad areas, but we want to focus on healthcare. That's a grand decision. But then do exactly what? Zero in the solving problem of access. That's the, I would say, you go to any biomedical conference. So what is the number one problem? Majority time they say access. This was proven amply in world of COVID, where doctors were afraid of approaching patients. We have done work with quarantines also in Pune. And so our wireless technology would have been very, very relevant to quarantines because doctors were afraid of entering a big tent with 700 COVID patients. And anyway, so the access is the number one problem. And so what is the problem we are, which I previously showed already, anytime, any place, any disease, any terrain, and so that anything. And this led to then begin system engineering exercise. And there are systemic requirements. I will actually show charts, what we mean by systemic requirements, what that led to. And then it led to, okay, all this is a grand systemic requirements. Okay, so what? Where that you need a solid products, which will actually meet the systemic requirements. Now, each product, what are the specifications of those products? What each product will do, should do. What are those products? And each is needs to be a deep product. Now I will point out what I am talking about. So there is a complex product engineering exercise, proven they continuously evolve by engaging with the real world users, market. They continuously evolve to come up with the correct set of products. And okay, fine. So can we do it? Well, no, you need lots of R&D, innovations, IP, patentable technologies. And we identify the specific technologies, innovations, inventions, and that is our lifeblood, which is needed. And there are several patentable technologies we identified which needed to be developed. And of course, you know what that means: invest, invest, and invest, and execute. And this is an ongoing exercise because for obvious reasons. And again, that is not enough. You have to validate the products by running in the field on tens of thousands of patients and seen by tens of doctors, top doctors. Yes, this is all works correct, is ready to be launched nationwide, even worldwide. So then we actually launch. Now you will say, doctor, all this is fine. Where is the proof of pudding? So I will share some numbers. So what is our footprint? What impact we have made? But we traverse this roadmap to end up at where we are. Applications, one more time, we have seen it. Okay. Now, how we do it, we interviewed a number of expert doctors, lots of American doctors from John Hopkins and Harvard, and practicing doctors, and lots of Indian doctors, lots of NGOs, CSRs, top specialists of India. What would you want as a doctor who is remotely, wirelessly treating a patient, not treating or managing a case? I should have mentioned upfront, when you say wirelessly, okay, there's a patient side and there is a doctor side. Doctor side, you don't need anything except a smartphone. From there is doing all the actions. On the patient side, there are patient side units of different shapes and sizes, and they come in different avatars. So there are patient side unique, and in between there are constellation of cloud servers and wireless and all that. So I should have clarified upfront that doctor from his smartphone from Churchgate area is managing a case in Mayavati. Okay. Now, what if he is empowered, enabled with all sorts of capabilities? This goes into the world of product engineering. What exactly you need? What data you need? What capabilities you need? There's also patient in the background. He has his own rights. There's actually triage. Patient has rights, doctor has needs, capabilities, and patient side units, there are requirements whereby paramedic can do something to the patient. So we found out 50 different capabilities which need to be given to the empowered doctor, by which is managing the case. Don't go into all this, but anyway. So what are the implications of what I'm talking about? I talked that we solve the problem of unavailability of specialists. That is very commonsensical. What if the patient is in ambulance, is stuck in the Bombay traffic jam at 6 o'clock in the evening? My friend's mother died in a traffic jam, even though she was just 10 minutes away in a normal times from a hospital. So in ambulatory patients, there's another implication. I'm pointing out more closer to ground type of examples. The barrier of location is eliminated, and take healthcare to the rural India. We have worked with, there are villages in Sikkim, villages in Kutch, for example, villages in Kashmir, and all over villages in Chandrapur Naxalite area, which have benefited or are benefiting regularly from our technology. The rural areas, 66% of the population. These are some of the implications which some of you have already seen, could have guessed. Cardiac care, within golden hour intervention. As soon as there is a cardiac incident episode, a man on a bike can reach the patient's home in minutes. And through our technology, our top cardiologists can see immediately that this guy needs, let's say, a stent or a streptokinase injection. So all that can be arranged if the doctor knows. So, and 24% of the time, the patient's life can be saved by doing something very basic in case of a cardiac episode. Sit down, take aspirin, take massage. The cardiologists are telling us. So it is a timely intervention, has a big impact in world of cardiology. Other similar example not listed is the world of maternal mortality, saving troubled pregnancy. We are among the worst in the world in MMR. So just for the troubled pregnancy is a last trimester, a mother is asked to take a bed rest or to save the pregnancy, but the doctor also says, please see me every 2 weeks so I can monitor your pregnancy. And that itself can kill the pregnancy because the lady has to travel on a bullock cart or ST, and you can see the picture. And that itself can compromise a pregnancy, a troubled pregnancy, that is. That's all. That basic checkup routine can be done wirelessly using our technology. And that is, India needs it. And there is a company in USA which does only one thing, monitor troubled pregnancy. And LA, they had this, they used to advertise on TV. So there was the whole concept, even in USA. Patients at home, geriatric care, long-term monitoring, and Alzheimer cases or any of these COVID cases, we want to monitor for days and days or weeks. Well, it can be done through technology, wirelessly. And so I talked about pregnancy, fetal health. And so these are some of the implications, just to drive home the point why we are doing what we are doing. So, the doctor will have always access to the live conditions of the patient if he wishes. Any moment, and he can connect with the patient any second, and so on, and then act on it, manage. So remote patient management, which is our paradigm. Not many companies in the world are doing this in wireless world, by the way. Now, let's see. I mentioned about Army. I'll show you a 1-minute video clip, a very basic application of this. A live, video clip. We will. What I mean is, it's almost a real life situation. We have worked a lot of work. Just as I'm talking to you and demoing to you, we are not planning any demo. Same way I have talked to and demoed to General Huda, the head of Northern Command. He says, last year I lost 140 Jawans. Help me save just 2 lives. And they have listed number of requirements. We said, the IIT team, so we have all that right now. Basically, on a glacier, I will show you real life pictures. If there is a bullet wound, you have exactly 15 minutes, and they call it platinum 15 minutes. In 15 minutes, the emergency physician in AFMC, Armed Forces Medical College, Pune, can look at the Jawan in Siachen. He knows exactly where the internal injury is. They tell us 98% time, if we can take a look at the patient, the whole 360-degree view of the patient, we know exactly where the internal wound is. If you can see his tongue color, eye movements, speech, we know where the problem is and therefore what to do to buy precious few hours. In meantime, helicopter can lift the thing. So you can save a lot of lives. So we just, and that patient can be monitored live ICU level, step down ICU level by the Pune doctor. All these capabilities we demoed, actually, not demoed, piloted, and so on, live trial. And we did all this in Partapur, Udhampur, the headquarters of Northern Command, the AFMC, Pune, Ladakh, Leh, all these places we did live trials and, and so on. At home, this is it's a now epidemic with a geriatric patient at home, and very low cost. He can be monitored around the clock, geriatric patient, and that particular product is designed for grandmothers. It's so simple to operate, so it can be done, and this thing turns into a live bedside monitor, live monitoring, and remote doctor has a lot more information to basically take care of a geriatric. It's a detailed case, but I mean, interest of time, I'll just skip the at-home situation. So this is a cartoon-like simplification of what's going on. This upper left-hand corner is a patient somewhere. Let's say, once again, my favorite example, Siachen Glacier. We'll show you live pictures, real pictures. Is connected to a patient side unit, the white box. Like we have the newer version of it. Is connected to everything else is wireless. Doctor in Churchgate area or Pune is managing the case. That's all. Nothing. There are no wires anywhere. That's what is happening. There's a ton of software on the patient side unit and much more software on the cloud constellations. Now we will show you a short 1-minute video clip to give an intuitive idea of what's going on. This is please, it focuses on only one area, cardiology, and it's a very primitive application, but it gives a very good intuitive idea of what is possible. Acha. Ashish, and can we turn on that video?
Yes, sir.
Zishan.
Yes, sir. Yes, sir. You need to share it.
I stop sharing. I don't hear sound. Zaish, Zishan.
Sound आपको sharing करना है. Sound sharing. Yes, sir. Give us a minute. उसमें जाके सेटिंग में जाके साउंड.
The EMR Center for Health. A paramedic arrives at the patient's home with A3 mobile unit. He acquires applications. A man gets a sudden chest pain at his home. His wife calls the EMR Center for Health. A paramedic arrives at the patient's home with A3 mobile unit. He acquires high acuity 12-lead diagnostic quality ECG, takes picture of the patient and collects other physiological parameters. He then sends the record to the doctor's cell phone via SMS or email. Doctor immediately checks the record and informs the course of treatment to be taken to the paramedic. A patient's vital parameters and ECG can be acquired and sent from a running ambulance during the golden hour with high accuracy. This is one of the salient features of A3 technology. Patients' data from PHC can be sent to senior cardiologists affiliated with tertiary care hospital for an expert opinion. Hundreds of people can be screened with A3's technology in a single day. Printouts of the reports can be taken at any point of time, which are permanently archived on the cloud-based server.
Yes, sir. Please, you can continue.
Yeah, okay. You can see, right, Zishan?
Yes, sir. Yes, sir. We can. Yes, sir. We can see.
Okay. Now, I told you why it is important. It is critical, and that's the only way forward. It's the number one health problem. It can make a national impact. Our nation needs it. By the way, we are partially owned by IIT Bombay. So in one sense, we have public-private partnership. Anyway, all that you agreed and the overall concept, the impact it can make, and we show you a video. By the way, everyone in this video was real, except patient was not patient because his wife was the real wife. That cardiologist was a top cardiologist, Dr. Pandit, and so on. Anyway, so given all that, what do we do next? To continue the system engineering exercise, we need a breadth of solutions or product portfolio. There are many ways of touching patient and giving him different services, which I listed earlier. In India, healthcare begins with Asha worker ANM, who goes from hut to hut, doing phenomenal work. And about a couple of years ago, they got a UNO award, WHO award, I think. It was a very prestigious thing. There are a million of them. So there's a solution which will empower them, create, and enable their work or make it life simpler, doable. So there is a product called ANM, auxiliary nurse midwife. It's the simplest of all products. Then action shifts to in India to a public health center, public health management. It could be a mobile medical unit or it could be GP clinic and so on. So that lady Asha worker may request the Adivasi woman, please visit a mobile medical unit which comes to your village every 2nd day. It's a real life story. So it's a different way of touching, the patient, serving patient. So there's a separate product for it. It is a very deep product. These are concepts and you have to develop it, try it, test it and evolve it, and it goes through several iterations and so on. Then that the patient may be required to move to a tertiary clinic, a community health center, or a small nursing home. In India, there are small places like Roa, Revdanda, Alibag. Alibag is there are larger nursing homes, 10, 20 bed hospitals, but they have only one specialty, internal medicine or gynecology. So anyway, so there are the ways of empowering them. So there is a Criti Light and there's a product called Criti View. It's our Rafale model, fighter jet model. It can do all, say, offensive, defensive. It's a very rich, very deep product. Criti View, the large hospital will find it very useful. You can put it in OPD, emergency room, community outreach centers, ICU center, step down or keep it at home. So it's a Criti View is that product. So you can see the progression is touched by Asha worker or a community health center, or a mobile medical unit. But there are variations of it, GP clinics, e-clinic, then it moves to a larger district hospital, say. Then the patient is discharged, he moves to an ambulance. So it could be ambulatory case. Then the patient is taken to his home to recuperate there faster even than a hospital. So we need a separate product for home care. what I can give to AIMS Delhi, by the way, their live trial or product, I cannot give it to a grandmother who is taking care of her husband. It has to be very, dumbed down, very simple product. So HQ, home quarantine, that's the name of it. And then there is an outlier product, military, Kriti Mill, which is again a different requirements. All this we arrived at by, complex product engineering. Began with certain wish and dream in the eyes, then we filter it down to systemic requirement. Now we have come down to ground level, the product requirements. All these are real products and will show you real pictures. And there is a very simple ECG product which does wireless ECG, which is actually a very popular product. We were not planning to be in that business. But anyway, so between these 7 products or 8, depending how you count, you are basically able to corner the patient anywhere and give him the correct service. All this talks to multiple cloud servers. We call them Kriti Serve. Now, that was the breadth of the solutions, and this is the depth. Now, it gets very complicated here. X-axis says it's a patient-centric axis. You have to treat, as I said, variety of disease, and that x-axis goes to the right, maybe 2 feet in the room. We have shown some samples, emergency cuts and wound, and e-home care and radiology. It could be basically anything, blood chemistry, blood problems, or otoscopy, and so on. That is a patient-centric. Y-axis is a doctor-centric axis, which says these are the capabilities. Remember 50 capabilities I was talking about? These are the capabilities by which doctor treats remotely from his smartphone or some LCD internet screen, x-axis. So, just think of this concept of combinatorial explosions. Start doing simple multiplication. And all this has to run on India, that is Bharat. And there are 14 grand requirements to make it India, that is Bharat proof, India proof. General Huda, by the way, was amused by this phrase, India proof. What are those India proofing requirements? First of all, the communication channel, you cannot assume any infrastructure working, no power, no capacity to pay, bad wireless networks. It has to handle all of this. It has to be ultra high precision. The bandwidth requirement has to be ultra low. We are 1.4 billion people. If there is a health camp, let's say in Chandrapur, Naxalite village, there will be immediately a queue of 300 tribal people. If you don't take care of all of them, there can be riot. So it has to process designed for volumes. 300 in a day in a camp. So volume is important. Speed. As soon as a record is captured, immediately that remote doctor should see it in seconds. It has to be completely mobile. Now I will show you a smart healthcare, smart village pictures. Speed, mobility, turnaround time, I told you, cost. After initial investment, the per transaction cost to be near zero. This is India, which has, so much percentage below BPL. It should protect patients' interest. Patients should be able to remain part of the scene. The whole thing should be expandable, customizable, and so on. It's a list of 14 grant requirements. The end goal is to create OPD in the pocket of the doctor sitting in Churchgate, or emergency room in the, on the smartphone, or patient bedside on the smartphone. That is the end goal. This is the depth of the product portfolio. And as you can see, beginning with our dream statement, what we want to do anywhere, anytime, any disease, terrain, situations, and variety of, and we have come to this level. And the requirements are proliferating. So this is what we call depth of the solutions, our approach, or so as a result of following the roadmap, this is where we ended up. And our investments were driven by this. Why it is difficult and why it is complex, you may not care for this slide. It is a bit technical. You have to balance so many components: cost, ultra reliability, guaranteed, no compromise, high speed, ultra high and high acuity precision, design for scaling up, spectrum of disease, bottom of the pyramid, design for that, and doctors should trust you. There are several treatment models. I didn't talk about it. Hub and spoke, emergency medicine, camps, in hospital, at home. There are different called rural PHC, okay, or smart home in a smart village, smart healthcare. There are all different service models. I mean, what are some of the technologies used in this? Wireless, algorithms, mathematics, cognitive. By the way, this is big part is patented. What you are, we are talking about. Product engineering is a science by itself. Cloud technology, we have sitting on a huge amount of priceless data after years of this or work. So on that data, we are doing something interesting work. We have presented this whole concept in a multiple perspective, multiple dimensions in multiple international conferences. And we got uniformly, at the cost of sounding little self-serving, we got uniformly extremely high praise. This has implication for epidemic management, for example, rural healthcare, and so on. So areas of application to summarize are primary healthcare center, defense, district hospitals, MMU, ambulance, tertiary. And again, some applications are drilled down in detail. So hub and spoke model, the primary healthcare center will be Rohan and Revdanda, hospital will be in New Bombay. And so it saves patients traveling time and money. You can save lives, decongest the district hospital, and everything is digitized. The thing is, paper based. It's all paperless. Everything you see, use saving on paper. Next to useful analytics is possible. And there's a very interesting project going on in Thane. I'll show you the real pictures where mobile medical unit goes from slum to slum. After a year, they took a step back. What impact we had, and based on our data, some beautiful reports were generated. Each patient came how many times? There's a patient, Manisha, who came 40 times. Over 40 times, what were the improvement in the parameters? Anyway, we could prove, the doctor could prove, okay, yes, there is an impact of this technology. And so this beautiful analytics is possible. Health camps, over 1,000 places, large health camps have been held. And I will show you some pictures also. But, as I say, the cost efficient health camps are possible. Because if in our a day, if you process 40 patients versus process 200 patients, the whole economics changes. And health camps can be variety of type. Pregnancies, general physical examination, cardiac camps, and on and on. So emergency medical service, the 911 thing. You can read MMUs. Mother and child. We are doing a lot of work in the mother and child, and there's a lot of emphasis by government on it. So you don't need to travel for NST or just to do a hospital heartbeats. Asha worker can go with A3. You need to track the health of the mother and the whole family. What is the stillbirth? How many stillbirths the lady had? The malnourished lady. When they got married, they track in phenomenal detail through our technology. And often the lives can be saved by doing something simple, by simple counseling and so on. There is a big area we are doing work on mother and child. Some more application areas, assisted living center. There's a Dignity Foundation in Karjat. All of their inmates were scanned, processed using our technology. Patients at home, two very prominent families, they had this technology at home. I can't name them, patients at home, Okay. Now, data is in fashion, AI is in fashion. You know that. We have lots of data. Some people express interest in licensing it. But you can collect lots of data, clinical data, for example, through our technology. Massive amount of data, clinical data. We are sitting on over 100,000 ultra high acuity ECGs, they all digital. we are sitting on lakhs of PSC type of records. What patients came in, what was his background, genealogy, and so on. What was his complaint or her complaints, and so on. What are the symptoms, and what did the doctor prescribe? What what he saw. What is his diagnosis? We have lakhs of such data, which will be used to train ChatGPT style model. Then remember, now see the power of it. You just give that capability to somebody, let's say on a border area in desert, Rajasthan. An initial thing, a local paramedic can get on there immediately, can enter the same thing. This is genealogy, this is the background, this is the biometrics, the complaints, symptoms. Okay, what do you think is going on? Anyway, that sort of thing. Okay. So we presented a paper in international conference in New York. Using this data, you can do epidemic management. Okay, so where is say in Kolhapur, there is a new emerging epidemic of conjunctivitis. Because of our real-time capability, you can track emerging trends. And let's say from Kolhapur, it moves to Solapur. You can track the movement, geographic. So it is a huge help in epidemic management. I won't go into the detail of all that. Okay, so implications, areas of applications, and so on. This is our current footprint, our 300 locations, 17 states, where our technology goes there periodically. It's permanently there or periodically goes every few days. So from Sikkim to Jammu to Tamil Nadu to Kutch and on and on. So 17 states. That's a nice footprint. In addition, there are 1,000+ locations. So total 1,300 locations where we have touched the patients, and camps have been held. So if you see the simple multiplication, we have touched the population base of millions. If we touch less than 100,000 patients, it touches 100,000 families, that sort of thing. Now some numbers, real numbers. So far, we have served 950,000 patients in 17 locations, 17 states, 1,300 locations, so on. For currently, we touch anywhere from 1.5 lakh to 2 lakh patients. Remember the first principle, concern for common man, and where we have traveled, we are talking about actual impact. All health insurance companies use our records because we are known for precision. So that's very important. It's based on a mathematics called DSP, digital signal processing. So that's one implications of what we do. Insurance company trust our records because all OHS, occupational health services camps, will have where they will use our technology. We generate EMR based on which insurance company makes the decision, yay or nay. Now some actual pictures. Now the original thing, the proof of pudding. This is in a secret location on Siachen Glacier, about 1 kilometer from Chinese border. And actually, I can share the name. It's a place called Gulab Post. It's right on the glacier. So our people, who you can see in the plain clothes, they train military doctors, and you can see our military product in upper left-hand corner, military product. So which can be thrown from a 15 feet high from a helicopter, and or it can be kept permanently in a post, and immediately can be connected, and immediately seconds, the remote doctor will see it. Okay, so now you can see this is in action, and we took 2-3 months. So I know there are some questions from the audience, but we'll take them all together. I love to answer all the questions. Anyway, this is to get this permission. They took 2-3 months to allow our team to travel to that secret location. You can see a lot of ice in the background. We invited Tata Network to bring in VSAT technology. And they did all that with their 150 kg of equipment at their expense. So you can see it's fairly dramatic. So at one end, you see this military application. As I said, we have been to Pune and all that. Armed Forces Medical College, Partapur, Udhampur, all the bases, army. several. Some more army pictures. This is a totally different setup. There's a famous eye hospital in Belgaum called Sharda Netralaya. For years they've been, heavy user of our technology. You can see one of our equipment in the picture. Any patient which enters the doors of Sharda Netralaya gets processed by our technology. The remote doctors will actually study the patient. Okay, is it worthy of cataract or not, and that sort of thing. And they have processed thousands and thousands and thousands of patients. This is a picture from the same hospital. These are all poor patients. So first was military. Now we are in world of eye care. The next setting. This is the world of small nursing homes. And India is dotted with them. It will be headed by typically by husband and wife team. Both MD doctors, but they want any other specialty. So this is a perfect way of roping in more specialties. These are all real life patients, real life paramedics and so on. So that's another setting. This is the setting of a CSC, Community Health Center. That lady is, orange is Dr. Daksha, very service oriented lady, Dr. Daksha Patel. They operated.
In the interest of time, if we could just move on a bit faster.
I will just give me 2 minutes. 2 minutes.
Yeah, sure. Yeah, thank you. Please continue.
This is yet another setting that was nursing home. This is the, the next one was CSC. This one is a smart health in a smart village. The first time in India it was tried, village Muri. This is a smart healthcare, and we trained non-English, non-Hindi speaking Telugu women. We are very smart. Our ladies are very intelligent. They picked up in an hour, and they train other ladies, and they processed other patients, believe it or not. So these are the, the training camp, and there are actually machine in usage. These are again some more pictures of smart village, work. This is a large health camps we organized, two on request of Maharashtra government. Both were hard camps. One Nandarpar or Jalgaon. There were, it was a huge crowd. I was telling you. So if you don't take care of all of them, there can be riot. So that's another scenario setting. So the actual pictures from the hut camp. This is an interesting one, mobile medical unit. In Thana, slums of Thana, there are 22 slums where a medical unit goes from slum to slum. Per day, they cover 2 or 3. And it is equipped with our wireless technology. One of our products called Pretty PHM. And it's, it's very regularly goes to each slum. Here are the pictures, actual pictures. And these are all, everything is real. I mean, real patient, real, everything real. And it is measured, it is making a social impact. And some patients come over and over again, and that is what public health management is all about. And the famous patient Manisha, who has come 40 times in 1 year. So I'm quite amused by it. And we can track even individual patient level, how she has improved as she came 3-4 times, what medicine was given, and on and on. These are actually MMU, yet another scenario. And here is PHC. The KM hospital has a famous PHC in Pabal. So it's a village 80 kilometers away. There they have a very popular PHC. And the whole thing is empowered by us, our technology. You can see that thing. It's running only on our technology, nothing else. That's yet another scenario. And this is incredible. There's an organization called Soham, operational in Pune. They are also known as Doctors for Beggars. They only treat beggars and destitutes. So they visit 60 sites all over Pune district. Temples, mosques, gurudwaras, churches where these typically destitutes are. And this lady, Dr. Sona, has won a lot of awards. This is technology is God sent, because I can get the doctor, I mean, the patient who is actually a destitute. You say go to a hospital, he'll never go. But right from there and there, I can give him service. So this is a picture, live pictures from that. And there are a lot of gory pictures, which I'm not showing. So this is yet another, I showed you 9 different settings of our technology. So all things began with the first principles, concern for common man unto the last, towards saving 1 million lives. And we think we have gotten, Steve Jobs used to say, I have gotten the phone. We believe this is the way of doing remote wireless healthcare. This is the way. WhatsApp video call is not it. You need to do all of this heavy lifting. And I showed you the complex flowchart. We followed the roadmap. So I think I'll stop there. Any questions, comments? I can answer as many questions as you want.
Thank you so much, Doctor. So we have some questions already in the chat box. So I just read out what is the first question. So the first question is from Zishan. So if remote monitoring involves handling sensitive patient data across various networks, what measure does A3RMP implement to ensure data security and patient confidentiality?
Oh, yes. Everything, all our information is encrypted. Only the organization who has adopted our technology has access to the data, that EMRs, electronic medical records, and the patient has the access to his own. And it's all like your banking portal, is password protected. Yeah, that is the first requirement. Agree.
The next question is from one of our colleagues, Pavitra Sharma. She wants to know what key milestones or technological breakthroughs can we expect from A3RMT as digital healthcare evolves? How this will shape the future of remote patient management? So any new developments in the pipeline?
Yes, we have a long pipeline of innovations. Innovations we know to turn them, productize them. For example, as we speak, we are building that AI-based that system. Okay, let me tell you, to build such a fancy thing, you need a massive amount of high-quality real-life data, which we happen to have. I say 950,000 patients we have touched. So we have lakhs of PSC type of data. Somebody comes with, you know what I mean. These are the symptoms. This is my background. These are the complaints, and doctor will figure out what's wrong with him. We have lakhs of such records. So we are building a model, which we are training that model to give a very accurate, okay, based on our data, lakhs of data. Same, that's one interesting thing coming on the pipeline. There are many such products. Yeah, yeah.
Thank you so much, sir. The next question is from Mr. Nikhil Kochar, who is one of our senior partners from Delhi. First of all, he has complimented you on this brilliant concept, which was implemented so effectively. What he would like to know is how much time did it take to implement this, and what was the cost of the project, and how is the government now using it across remote districts?
Okay. To answer, okay, it took, because we are pioneers, we boldly stuck out our neck, put our neck on line. Okay, this is the future. This is the way we want to go. Trust me, this concept is remote patient management, general, not a point solution. It's still a new thing for USA, believe it or not. In India, it is, we will be few steps behind. So there's a good side. Silicon Valley will love this kind of bold initiatives. So it took it some years to traverse this path, what it will take to do what the impact we are making. And I gave you several proofs and examples. So it took several years to exactly point out what we need to do. And we actually invested fair amount of money. A lot of that came from our own pocket, some from private investor. An important thing, oh yes, the original seed funding came from a World Bank program and outright Government of India award, grant come award. It was an honor. So with that, we got off the ground, we pumped in a lot of our own personal money, and we got some private investors. It took some years, And other thing is, in this business, you have to run the products for years and years to build that trust. I mean, this is a medical product. You are playing with somebody's life. So yes, yeah, it took several years. If you want a number, we actively started marketing all this in serious manner, maybe 5-6 years ago, and all our installations have come strictly by referrals. Believe it or not, people have heard about us and they come on their own. So that is how we work, and we are a bit ahead of the time. So we know that we don't want to blow up money in convincing the communities and the country, do this, do this. So the people are also rising up to possibilities and requirement. We need to give access. COVID helped some. So it's all of the above.
Thank you, sir. So, the next question is from our colleague, Mr. Josefa Kaka. So this is one on the technical side. So what he's asking is, when we have monsoon-prone areas or flooding where medical care is required. So is this technology or the hardware IP67 certified or any higher technology, so that even in harsh climatic conditions, the quality is not compromised?
Exactly. Frankly, I joke that ours is a Mars rover concept. NASA just dropped it on Mars, and that's it. It can't expect anything from the environment. Same way in a disaster zone, our box machine can be dropped, like military box I showed you. You turn it on, it's ready to go. It can be solar powered. It talks wirelessly to the cloud servers and to remote doctors and hospitals. So in the disaster, actually, we are in dialogue right now with the Central Disaster Relief Institute. They obviously see the value of this. But you got it right. In disaster management, this has a huge relevance.
The next question is,
believe it or not, the lowest level of operation works only from 20 to 30 kbps, and the ICU level remote monitoring step down works from 70 to 80 kbps. But there some people in Navy got interested. This is great for us. But anyway, with government, we don't have yet a government customer. We have not tried also, but we have, like with Army, we did a lot of work. We are invited by the Defense Ministry. So it went quite a distance. So we are relevant to them and so on.
Thank you so much, sir. One last question from one of our Delhi partners, Mr. Vinod Jaiswal. So, what are the limitations of diagnosing conditions remotely? So, is there any risk of misdiagnosis or insufficient information, and how do we tackle that?
Yeah, that's a very good question. Because of COVID experience, government softened is remote consulting, legal requirements. It has softened, so you can do a lot of things now. And the idea is, once a doctor, regardless of anything else, doctor sees exactly the condition and what's going on. He can even interview. I didn't talk about it. The touch of the button, without knowing where in the world the patient is, doctor can be face to face with the patient and talk to him, see his tongue color, see his speech, see his eye movement, see the wound. He can do all those things and see him at ICU level. So he knows a lot. He can make a lot of suggestions, like lie down, do massaging, take also aspirin. And the government also liberalized the laws in this realm, because they also realize we have to enable remote medicine.
Thank you, Dr. Parikh. I think it has been a privilege to learn about this fantastic technology, and it's really amazing what technology can do to alleviate the health concerns of people who are in remote locations. I would just request my colleague, Mr. Josefa Kaka, to give a vote of thanks for this fantastic session that we have had. Mr. Kaka, please.
Good evening, Dr. Parikh.
Yes.
Thank you for On behalf of GHS, I would sincerely like to thank you for this insightful and engaging session on the Medicare space and the technology that you have developed. So in this healthcare industry, this will be a real big revolution. And your journey throughout serving the nation better, as you mentioned, Bharat Desh. I say this Swadesh tool will help everyone, everywhere and anytime. So hats off to you, sir. Salutes to you. Thank you. Thank you once again for this insight.
Yeah.
Thank you.
It was a delight to engage with such an intelligent audience.
Dr. Parikh, also few words of appreciation from my side. Of course, I have seen this technology before in action and we have met in person. But you deserve a very big round of applause. I think it is a seva of lifetime to all the Indians. And having already topped 1 million lives is no small achievement. You have done a great human service to our country, and we are extremely proud of your achievements. Thank you so
Thank
much
you.
for sharing your knowledge, your solutions, and the remote technology. Thank you so much.
I would request everybody to close this with a huge round of applause for Dr. Parikh.